Good afternoon, everyone. I am delighted to be hosting SRUK's third webinar in recent times. This webinar will be looking at digital ulcers. The webinar will be structured in two parts. Part one will be a presentation and part two will be a live Q&A. The agenda for the presentation includes treatments, preventions, and tips, and a number of other key topics. I am very happy to be joined by our expert speaker, Dr. Ariane Herrick. Hello, Dr. Herrick, how are you?
Fine, thank you.
Fantastic. Dr. Herrick is a professor of rheumatology at the University of Manchester and an honorary consultant rheumatologist at Salford Royal NHS Foundation Trust. Her main clinical and research interests are Raynaud's phenomenon and systemic sclerosis spectrum disorders, which puts her in a great position to be leading this webinar. She is also a past president of the Scleroderma Clinical Trials Consortium and is a current vice president of SRUK. I can see the number of attendees is growing. Currently we're on 40. I just want to give a few more moments for as many people to join us as possible. I'll just have a look at who we can see. So I can see we're joined by Andrea, Anita, Cara, Gemma, Helen. I won't go through all the names, not to worry. I'll just give a few more moments to try and get a few more people to join us before we begin. And, oh, we've just received a little hello message from Edith. Hello, Edith. So without further ado, I'd like to hand over to Dr. Herrick, who will be sharing her screen.
Well, thank you very much for the kind introduction. And I should just start by saying that I'm very grateful to SRUK for the opportunity to take part in this session and to talk about a subject which I think is very important for many of you who are listening here, and that's the assessment and management of digital ulcers in people with systemic sclerosis. Now, I'm going to cover the different points on this screen here. I'm going to talk about what are digital ulcers, and that's maybe not such a simple question as it sounds. I'm going to talk about who is particularly at risk of developing a digital ulcer, why ulcers develop, where they develop, how do we know if an ulcer is infected. I'm going to talk about prevention of ulcers and the treatment of ulcers once they've occurred. And finally, just a few quick tips to conclude. So first of all, what are digital ulcers? Now, digital ulcers are sores, perhaps for lack of a better expression, of the fingers or the toes. So by digital in this sense, we mean fingers or toes. And I'm going to show this slide on this picture on the right again and go through one or two of the different points which are exemplified on the slide. But just to say, they're often extremely painful. Many of you don't need me to tell you that. But I think their appearance often belies, the severity of the pain and the impact on quality of life which they can be associated with. And examples of different ulcers, which, as I say, I'm going to go through on future slides, are shown on the right. So there's a great range of lesions, as you can see here. So who is at particular risk of developing a digital ulcer? Well, those of you who have systemic sclerosis, and I'll probably use the term scleroderma from now on, as it's a little bit simpler to say, and I think it's probably more commonly used, but those with scleroderma are at risk of digital ulcers. And in fact, approximately half of people with scleroderma at some point in their clinical course will develop a digital ulcer. So it is a very good chance that you're going to have at some point a digital ulcer. We did a study some years ago, which was very generously funded by what was at that time the Raynaud's and Scleroderma Association, looking at prevalence of digital ulcers. And in fact, we found that at any one time, people coming through the clinic at Salford Royal did demonstrate a very high prevalence of digital ulcers, and just coming to a routine appointment, about 10% of people had an ulcer at any one time. So it just shows you how common these are in the population of people with scleroderma. I think it's a very important point to reassure those of you listening with primary Raynaud's that primary Raynaud's is not associated with digital ulceration. In fact, it's one of the defining features of primary Raynaud's that you do not go on and develop any permanent damage to the tips of the fingers or toes. And just to backtrack to the last point on this slide, if someone with Raynaud's does develop a digital ulcer, then I think you have to think twice about the diagnosis of primary Raynaud's. And this could be an early indication that that person is developing systemic sclerosis. It may not be, it may be something completely different. You can obviously have sores for different reasons in the fingers, but nonetheless, it would raise some concern and it ought to be checked out. And amongst those who definitely have scleroderma, then there are groups of people who are more likely to develop an ulcer than others. And those who are most likely to develop an ulcer are those who have already had one. We know that if you've already had an ulcer, then you're more likely to get another one. And also those who have a particularly poor blood supply to their fingers. And you could say, well, how do we know that? Well, we know that because they maybe have particularly severe Raynaud's phenomenon. Of course, a lot of people with scleroderma do have severe Raynaud's, but those with particularly severe Raynaud's usually do know about it. And also when we do some tests, for example, some of you will have a test called nail fold capillaroscopy, when we look at the small blood vessels underneath at the nail fold. And we know that people with particularly severe changes on nail fold capillaroscopy or particularly severe changes on thermographic imaging, temperature maps of their fingers, if you've had that testing, we do know that people with these abnormalities, or at least the most severe abnormalities, are most likely to get a digital ulcer. So then moving on to why and where ulcers develop. So we think it's not, we always want to know more about digital ulcers, and we don't pretend as doctors and scientists who are interested in digital ulcers, we don't pretend to have all the answers about why they develop. But we do think that a major driving source is a poor blood supply to the fingers and toes. Because we know that in people with scleroderma, the blood supply to the fingers and toes can be very severely compromised. And we think that's what leads, you know, to the damaged tissues which can ulcerate. We also think that so-called mechanical factors, for example, repetitive low-grade trauma, you know, banging your fingers, the tips of the fingers are inevitably going to be subject to trauma, using a keyboard and all sorts of things. We can't avoid that. We have to go around our everyday lives. But sometimes, you know, at sites which are particularly prone to repetitive trauma, albeit low grade, then we think that that could be an influencing factor. And also, for example, here, this patient who has ulcers over these very marked, what we call contractures of the fingers, these are liable to get repetitively, you know, traumatized just throughout activities of everyday living. And so we think that that contributes to the development of an ulcer, a sort of pressure effect, as it were, from the tight skin. Underlying calcium can predispose, because we can see some calcium here underneath the finger shown in X-ray, and when that calcium lump gets very large and puts a pressure on the skin overlying it, then it can ulcerate. And I'll come back to that later, but that can really lead to quite a big problem with ulceration. Or you could have a combination of these three. They're not mutually exclusive, and certainly two factors, and maybe three in those with calcinosis, could all be contributory. So where do they develop? Well, this is exemplified by the pictures which we can see here. And the tips of the the tips of the fingers are probably most commonly affected. And many of you will know that, and you can get an ulcer as shown here, right at the tip of the finger. And this is a very common site to have a digital ulcer. The other common site where ulcers can develop is over what we call the extensor aspects of the fingers. And most commonly this occurs when the fingers are bent or contracted because of the scleroderma process. Unfortunately, as many of you know, when you have scleroderma, the skin can get tight, especially in the fingers, and sometimes the severity of that tightness is so great that the fingers bend. And in this patient here, that's really been a very substantial bending, and of course because of that there's a predisposition to getting ulcers at these sites. And for example, here's really quite a nasty ulcer, there's a little bit of pus underneath it there, and you can get a lot of problems with these, and they can be very difficult to heal, as I'm sure many of you know. Then this person here has got some calcium. It's a little bit difficult to see on this picture, but here's an X-ray. X-rays show calcium or calcinosis very beautifully because it's what we call radio opaque, and we can see the calcium there. And sometimes, as again, many of you will know this, but the calcium lumps can actually get bigger and then actually break out through the skin. And when that happens, of course, an ulcer forms. Sometimes it can heal very quickly, and in fact, some people quite like it when that happens because it decompresses, you know, the area, and it actually makes the finger feel a bit better after that. But unfortunately, it does give this wound, and sometimes that can be quite difficult to heal. And you occasionally get ulcers at other sites, for example, at the side of the finger, as shown here, and also at the nail bed. But these are more unusual sites, but they can occur. So several different areas that ulcers can develop. So how would we know that an ulcer was infected? And we're always a little bit worried that ulcers become infected. Because it's a break in the skin, then it is going to be subject to the risk of infection. And unfortunately, finger and toe ulcers often become infected. And I think sometimes that infection is maybe not recognized, because I think there often is a low-grade infection in these ulcers. And how might you know that an ulcer was infected? Well, you would experience increased pain, probably. There might be some redness around the wound or the ulcer site. There might be discharge of pus from the ulcer, so it might be green or yellow around the ulcer and over the surface of it. And sometimes if you get quite a nasty infection, then the whole area can become swollen. For example, if it's an ulcer at the tip of the finger, then the whole tip of the finger might get quite swollen and angry looking. So usually you would get some indication of that. And you do have to be careful about this, because I don't want to be alarmist, but infection can spread. It can spread up the finger or up the toe, and it can also spread down into the underlying bone. And we always worry about bone infection in people with scleroderma, because if you get, well, any infection in the finger, but particularly if you get bone infection, it can really be very difficult to heal and to overcome the infection because of the compromised blood supply, which just makes everything more difficult to get better. And when we particularly worry about bone infection is when the pain has been going on quite a long time. And also the bone, if you press it, is often very tender. And you can have very major pain. Any ulcer, but particularly one with bone infection, can, as I said earlier, be very painful. It can keep you awake at night. And it can really have a very major impact, as I said earlier, on quality of life. And we always worry about infection, and we will swab the ulcer. We can take an X-ray of the ulcer, sometimes or the finger or toe. Sometimes X-rays aren't really so helpful, because especially, for example, if the finger is contracted, as I showed you in the earlier picture, an X-ray will have difficulty showing the actual site of the infection. And in fact, changes on X-ray, bony changes on X-ray, occur very late. So for that reason, there's an increased tendency now to ask for MR imaging. Some of you will have had MR or magnetic resonance imaging of ulcers. because these can show at an early stage underlying bone infection. They're not perfect, and sometimes it's a little bit difficult to say, but sometimes they can give an early warning. So we're always very careful to watch out for infection. So what can you do, what can we all do to try to prevent the development of digital ulcers? Because of course, you know, the usual aphorism that prevention is much better than cure. And there are a few things that you can do. Sometimes ulcers, in fact, very often, I regret to say, they are unavoidable. They're part of the disease process, but we can try and do as much as we can to prevent them happening. I think skin protection is important, and you know, a lot of you will have found ways of protecting your skin, maybe by putting a dressing over a particular area that's very subject to trauma, or if you get an early ulcer, then making very sure that it's protected. So and just being a little bit careful about using the hands and the feet. We mustn't forget about toe ulcers. I think because the hands are much more visible, we tend to concentrate on finger ulcers, but toe ulcers can be, as many of you will know, a huge problem in people with scleroderma, and good podiatry care is very important. For example, you have to prevent pressure points developing, and that means using good footwear. Maybe if you have some pressure points, then your podiatrist might mold an insole for you or recommend an insole for you, really just to relieve that pressure and to try to stop an ulcer developing, because foot ulcers you know, can be really very problematic to heal. So protecting the skin is important. If you smoke, then if at all possible, you should stop smoking. I'll come back to that. And certain medications, and I'm going to come back to that when I talk about the sort of drug treatment of digital ulcers, but there is a medication called bosentan, which some of you might be familiar with, and that is actually licensed to prevent ulcers in patients who have had a lot of ulcers already. So there are one or two medicines, and probably sildenafil, although the evidence is maybe not quite so strong. There is evidence to suggest that sildenafil may help to prevent development of digital ulcers. So we'll come back to that. But I think one of the most important aspects of prevention is maybe not so much to prevent an ulcer happening completely, but to prevent progression of an ulcer. And that is that as soon as you get an ulcer or think that you have an ulcer, then I think it is important to seek help about that, because so often we see digital ulcers, in my opinion, far too late. You know, we might see someone days or weeks after the ulcer is developed, and by which time it can really be a complete mess, and we just wish that we'd seen it earlier. Because if we do see them early, then we can suggest courses of treatment, which I'm going to come on to. So I think one of the key areas is to really get advice early, and we'll come back to that in the treatment algorithm. Stopping smoking is important. We know that if you have scleroderma, then if you smoke, your chances of getting a severe finger or toe problem are increased. You're more likely to require a surgical debridement. You're more likely to require to have to come into hospital for intravenous iloprost infusions. You're more likely, you know, fortunately this is rare, but unfortunately it's very serious to require an amputation of part of a finger or toe. So we know that smoking is bad news. I mean, one of the reasons it's bad news is that, as most of you will know, smoking predisposes to cardiovascular disease, it predisposes to heart disease, it also predisposes to what we call peripheral vascular disease. That's large vessel disease affecting especially the lower limbs. And if you have that large vessel disease, in addition to the disease of the smaller vessels, which characterizes the scleroderma disease process, and if you have both in combination, then really it can give a very major problem in terms of the blood supply of the foot. And I say the foot because large vessel disease is less common in the upper limbs than in the lower limbs. But the large vessel disease is certainly contributed to by smoking. So I hope I've made my point. This is very important to try and stop. And if you can get help, and you can get help to stop smoking, I appreciate that it's very difficult, but you really should think about that by accessing your local smoking cessation service through your GP or your local hospital. So now we're going to come on to treatment, which of course is the most, well, to some extent, something that we all want to know about. And there are treatments available. They're maybe not as good as we would like them to be, but I just want to go through the things in terms, because there just isn't one treatment for digital ulcers. There's a pathway of treatment which involves a whole lot of different elements. And I think they're all important in their own right. So if we go through this treatment of digital ulceration, as I said earlier, I think the first point really is to seek medical attention early if you do develop a digital ulcer. And over the years, you all get to know your fingers and toes very well, better than anybody else. So you often know the sort of lesion that's likely to progress. And so you will know yourself to some extent. But maybe if you haven't had an ulcer before, or if you're in any doubt whatsoever, then we would always advise you to seek medical advice. And certainly where I work in Salford, we have a helpline, and people do contact the helpline, and we see them give advice over the phone, or we will see them urgently at the clinic. It's interesting because I think practice has changed with the current pandemic, and I think there are some learning points for us to take forward into the hopefully post-pandemic era. For example, we're making much more use of patients sending us photographs, so we regularly get photographs sent to us, most days actually with pictures of finger ulcers, and that gives us a good idea of how bad it is. We can often see it's not as good as seeing someone directly, but nonetheless it gives us a good idea. We can often see from a photograph whether it's infected, so we can offer advice there, or offer to see the person if that's necessary. So I think it's important to seek advice early. Wound care is an important aspect of management, and that's where the nurse specialist role is very important, or the podiatrist. Both of these specialists are usually expert in wound care, particularly a specific nurse specialist with an interest in systemic sclerosis will usually know a lot about wound care. There are certain sort of very broad principles of management. Some of the wound care team will say, if it's a very wet, gooey ulcer, then maybe best to try and get it to dry a little bit. But if it's dry, then I think the view is that it's important to have some moisture to try and aid healing. So I think there are different dressings. I don't profess to be any authority on dressings whatsoever. I'm very lucky to work with Liz Ragg, who's a very experienced renal and scleroderma nurse specialist who runs a clinic for digital ulcers, so she knows a lot about dressings and would be able to advise. We have a very good podiatry team, so we're very lucky there, and they also would be able to advise on dressings. All hospitals will have a tissue viability service, so I think who will sometimes be involved. So I think the important thing is to get good advice. But many of you will have experimented with different dressings in the past, and you'll know what you like and what you feel is helpful and what's less helpful. I think it's important to remember pain relief, and we'll come back to that. So I'll leave that for just now, but it is a very important topic. Antibiotics, I think, are important if there's any question that there might be infection. And I must say, I do use a lot of antibiotics. We have to be careful about antibiotics. It's not a good idea to have, too many antibiotics, but nonetheless, I think that, these ulcers very often do have a low-grade infection. And in my experience, they're often improved substantially by giving an antibiotic, and that aids their healing. So I think that is important. And then different treatments to improve the blood flow. Now, most of you who have Raynaud's and scleroderma, or a lot certainly with systemic sclerosis, will be on these treatments. There are pathways to treat Raynaud's phenomenon, and so you probably will be on these medications already. And really, it's the same principle for improving the blood flow, because in a way, digital ulceration is almost an extension in people with systemic sclerosis or scleroderma of Raynaud's, in that it's a manifestation of the blood supply to the fingers. So just about everyone with scleroderma gets Raynaud's, and as I said earlier, about half go on to develop a more severe complication of digital ulceration. But improving the blood flow has the same principles for both. So usually the first line treatment is a type of drug called a calcium channel blocker, and many of you will be on these. Common ones are nifedipine or amlodipine, but there are several other ones which your doctor might prescribe. So you would always start at a low dose, because some people are very sensitive to them, and gradually increase the dose. So we'd make sure that you were in an optimal dose of a calcium channel blocker. If that didn't work, or if it wasn't tolerated, then we would add in, or if the calcium channel wasn't tolerated, we would substitute a type of drug called a phosphodiesterase inhibitor. Sildenafil is an example of a phosphodiesterase inhibitor, and that's Viagra, which you might have heard of. Some of you will be on sildenafil. We're using more and more sildenafil now, especially in people with systemic sclerosis, because it's probably it is a very effective drug if you can tolerate it. And so there is some evidence to suggest that it reduces the development, or at least it prevents some development of digital ulcers. So we use a lot of that. And I'll come back to this in a flow chart in a couple of slides' time. If all these things don't work in themselves, and you have a bad ulcer, then your doctor might recommend that you're admitted for intravenous infusions of a medication called Ilapros. Many of you will have had that. It necessitates hospitalization, which is obviously a nuisance because people don't, of course, want to come into hospital. But it's usually the usual regime. There are different regimes, but the one most people use in the UK is 5 days of infusion, single infusion each day, usually for 6 hours at a time. Some people will require surgery, the minority, and I'll come back to that, but sometimes it's useful just to do what's called a debridement and clean up some of the dead tissue and clean up the ulcer, and that can be helpful. Sometimes more extensive surgery is required. And the medication I mentioned earlier called Bosentan is licensed to prevent development of recurrent ulcers. It used to be that Bosentan was extremely difficult to get. It was very expensive. It's now, but we could get it if it was necessary. It's now out of patent, and so the price has come down now. And so I think people are going to be using Bosentan more, and probably before intravenous Ilapros, especially with COVID-19, we try to avoid hospitalizations where possible. And just to say a little bit about pain control, because I think this is sometimes forgotten about a little bit. These ulcers, as many of you know, are excruciating, and it is very important to have good pain management. And don't be afraid to ask your doctor. And sometimes people will require morphine for the pain of digital ulcers, because they really can be excruciating, and hopefully just for a short time until the ulcer heals, because obviously it's important to try not to take these very strong drugs for a long time. But you may just need some additional painkillers just while the ulcer is particularly problematic until it heals up. So just to put all that I've just said from the last slide into some sort of context, in the UK, we did go through an exercise with a group of people, some doctors with pharmacy and nursing and patient representative input. And this was published 5 years ago and published in the Journal of Rheumatology. And we actually looked at guidelines for Raynaud's and for digital ulcers in this paper. But I just want to show you one of the flow charts from that paper. And I just want to take a few minutes just to go through it, because I think it really makes all the points that I've just gone through, but it puts them into perspective a little bit. And also, I think this algorithm is already out of date. And you could say, well, why show it? Well, I actually deliberately showed it because I think it's good that it's out of date, because that shows that actually I've shown in with yellow stars where we've changed the pathway and moved it up the pathway, because it shows that we're continuing to progress, we're continuing to develop newer treatments, to examine newer treatments, and so we're trying to make as much progress as possible. So this is a reiteration of much that I've already said, but if you want to, for treatment of digital ulcers, the first thing is to identify the ulcer early, before the whole thing's gone and become a great big problem. You need to check if there's anything that's aggravating the ulcer, and that might be an infection which needs antibiotic treatment, and that's actually quite common. Or it may, as I referred to earlier when I was talking about smoking, but of course people can get large vessel disease without being smokers. Always consider, well, that's your doctor's responsibility, to always consider the possibility that as well as having the scleroderma, there's something else that requires attention. For example, if you do have what's called large vessel disease, peripheral vascular disease, then that could be contributing certainly to toe ulcer, or less frequently to finger ulcers. And we always need to think about that. So your doctor will feel your pulses just to see if you've got good pulses. And if you haven't, then he or she will probably want to do some further tests, because there might be something that needs something done about it. For example, what's called an angioplasty to dilate up an artery, if that's contributing to blood flow. So you need to think about all these things. Optimal wound care, I've spoken about, good nursing input and podiatry input, adequate analgesia, that means painkillers. And then after all that, you then go and look at what medications you're on, the patient's on, to maximize the blood flow. And you think, could I increase this? Is this optimal treatment, or is there something else that I can add in? This gold star here, I've moved up from PD5, means phosphodiesterase 5 inhibitor. That's something like sildenafil. We used to use that much lower down the pathway, but now they're probably second line treatment to a calcium channel blocker for people with scleroderma and bad Raynaud's or digital ulcers. So we would use them much earlier now. So I think that's actually a change over the last 5 years. And I think that is good. There have been several studies in Raynaud's phenomenon, and 1 or 2 studies in digital ulceration, suggesting that sildenafil or another one called tadalafil are helpful. So I think that's important. A lot of GPs are not comfortable to prescribe them for Raynaud's phenomenon and digital ulceration. Hopefully that will change, but your rheumatologist can otherwise prescribe them. And then, as I said earlier, think about removing any necrotic, that means dead tissue. And sometimes if an ulcer, for example, is very, very tender at the tip, then that might mean that there's some pus under it or some dead tissue that needs to be removed. If there's any calcinosis underlying it, then it just might be that that needs to be debulked. That's problematic. It's a very difficult situation. You can never completely remove calcinosis. You can only reduce its bulk a bit. But it's always worth considering by an experienced surgeon, a plastic surgeon or hand surgeon. Antiplatelet agents, that means things like aspirin or clopidogrel. They can stop the stickiness of the blood. And statins, of course, you probably all heard about for treatment of vessel disease. We don't know if these are helpful or not in scleroderma. I think that's the bottom line. There's a theoretical reason why they might be helpful, but you have to be very careful with aspirin because, for example, it might irritate the esophagus, and a lot of you will have esophageal problems. So we do have to weigh the pros and the cons of these approaches. And if none of these approaches are helpful and you still go on and get an ulcer or get more ulcers, then you would need to think, so I should have mentioned earlier there that I include there intravenous iloprost or prostacyclin, which is another one very similar to iloprost. Then if none of these work, then you would think about repeating the intravenous iloprost infusions, or you would think about this ERA as an abbreviation for endothelin receptor antagonist, which is bosentan. And again, I could maybe have put another gold star there as well. We did a meeting this morning of something called the UK Systemic Sclerosis Study Group, and we were just discussing, the positioning of bosentan in this pathway and how that's being re-looked at, because especially with COVID-19 and the wish to minimize hospitalizations, then I think bosentan is going to get moved up the pathway. So I think it will probably sit, higher up. Really, so that it comes before the intravenous iloprost infusion. So again, I think as we learn more about these drugs and as we become more familiar with them, then they change. And if all these things are ineffective, then we would need to go on and consider surgery. Fortunately, that is rarely necessary. So I think debridement is actually not so rare. And certainly I think it's a good idea. And I'm very lucky because we've got good access to surgical debridements, although it has been a bit more difficult with the current pandemic. But there are some other operations that can be considered. Digital sympathectomy is an operation which some of you will know about because you may have had it, and it cuts the sympathetic nerves which are thought to contribute to the poor blood supply in the fingers, and it also does something, it does what's called a decompression of some of the arteries in the hand, because you get too much connective tissue disease called adventitial tissue around the artery, and that can compress the artery, and the surgeon can debulk that and decompress it. It's a very specialized procedure, and it needs to be done by a specialist surgeon who's got experience in the technique. And sometimes the other thing that one of you or two of you might be wondering about are Botox injections. And I think the jury's out as to whether Botox injections might be helpful for treatment of bad finger problems in patients with scleroderma. And our hand surgeon certainly does often give Botox at the same time as a debridement, but it is a little bit contentious as to whether or not it's helpful. But some people think it is, and I think it's probably something that is a reasonable thing to consider. So to conclude, we've gone through a number of different things. We've discussed what digital ulcers are and who's at risk of developing them, why, where they develop, how do we know they're infected, prevention, treatment of digital ulcers. And just to conclude, there are very major causes we know of pain and disability. I can't emphasize the importance of early diagnosis, remembering that these can become infected, that there are several different aspects of treatment. There's not just one aspect, there's several different ones. So wound care and painkillers and antibiotics and medical treatments are all important. And I think there is a little bit of, I would like to reassure you that we're continuing to develop research projects to try and understand more about measuring digital ulcers and treating them. So thanks very much. And thank you for listening, everybody. I can't see you, of course, so it's I'm just looking at my computer screen. Thanks very much. And just to thank again Scleroderma Rhinos UK for hosting this meeting.
Thank you, Dr. Herrick. Thanks so much for that fantastic presentation. I'm sure our attendees took a lot of value from this very informative session. I'd like to now take this opportunity to encourage everybody to send in their questions, and you can do so by hovering over your Zoom app, and there is a Q&A icon that you can click on where you can send in your questions. So it's the Q&A icon, not the chat icon.
Okay, I can see a chat icon though, I think. Look, there was a question just when everyone else is thinking about them. Maybe do you want to repeat it? Did you see it?
I have. Can I kindly encourage everybody to send in their questions to the Q&A icon instead of the chat icon, just so we can make sure we can see all of the questions coming in. And I just want to give a moment for a few more questions to come in, but one has already come in from Kelly. And Kelly has thanked you for your presentation, Dr. Herrick, and she's gone on to ask, how can I distinguish between ulcers and calcinosis? She goes on to say, and randomly, I've also wondered why, since developing ulcers over 4 years ago, she has an ulcer on each finger and some of her knuckles, but they haven't appeared on her thumb. So they've only appeared on her finger and knuckles, but on her thumb, and she's asking if that is normal.
Okay. Okay, well, thank you very much, Kelly, for the question. I would like to say it's not, I didn't ask Kelly to answer this question. I've got a particular interest in the thumb, and some of my colleagues always laugh at me for that, because I think the thumb is a very interesting area, and I think it's actually going to help to answer your question. But just to answer them in turn, the issue about differentiating calcinosis from an ulcer. An ulcer is a break in the skin, you know, and you can have an ulcer overlying an area of calcinosis, or you can have calcinosis with or without an ulcer. And if you have very obvious calcinosis, you will know about it. You'll have a hard lump. And sometimes when it comes through skin, it will discharge sort of toothpaste-like material, or sometimes a little lump as well. And if you're in any doubt about whether you have calcinosis or not, then your doctor can take an x-ray of it, because it will be very obvious. You won't miss calcinosis with an x-ray. So if there's nothing in the x-ray, you will not have calcinosis. The question about your thumbs not being affected, that's very interesting. We know that Raynaud's, it relatively spares the thumb. That's quite well recognized. We've done some research in that, because the thumb actually has a better blood supply than the other fingers, and it's shorter as well. So maybe so for various reasons, you don't get so much Raynaud's and the thumb. And a lot of people will say that. They'll say that their thumb's relatively spared by Raynaud's. But in fact, the opposite is true of calcinosis. And of your fingers, well, if you count the thumb as a finger, the thumb and the index finger are the ones that are most likely to have calcinosis, or most affected. And I think that's probably a trauma issue, because your thumb and your index fingers are the ones that are, slapping around on things most often and pinching things. So it's interesting, because I think it tells us a little bit about the pathology of the ulcer. So I hope that answers your question. So if you're not sure if you have calcinosis, then ask your doctor to take an x-ray.
Thank you for that, Dr. Herrick. We'll now move on to a question from Sharon. And Sharon has also thanked you. She's gone on to ask, or to state, that she types for around 8 hours a day. And she is asking if that is a risk factor for ulcers of fingertips. Would that increase chances of developing ulcers in her fingertips?
I think that's an interesting point, Sharon. I think, I think if you have had no ulcers, I don't know. I don't want to, I'll just answer the question generally rather than for you as an individual. But I think if someone has systemic sclerosis, then, we have to go on and do our activities. It's important to be able to conduct our work and so forth. I think obviously if you're predisposed to finger ulcers, and you're typing for a lot of time, then that could aggravate them. I don't think we can say that typing per se will cause an ulcer, but it obviously does expose your fingers to low-grade trauma, and so potentially it's difficult to say that it wouldn't either. So I'm not answering your question probably very satisfactorily for you. I think the short answer is we don't know. I think if you've had ulcers, or someone has had ulcers with their fingers, then I think you just have to be a little bit careful and do what you can. I mean, there are obviously people who should speak to one's occupational therapist about, keyboards and things that perhaps are more conducive to not putting so much pressure on the fingers. There are various different ways around these problems.
Thank you, Dr. Herrick. We've also had a question coming from Liz. And Liz has asked for a recommendation for a particularly effective antibiotic.
Well, thanks as well. It's, the one that we use most often is flucloxacillin. And that's because the commonest organism to grow from ulcers is an organism called Staphylococcus aureus, which is usually quite sensitive to flucloxacillin. So that's one that we usually use. However, some people are allergic. Flucloxacillin is a type of penicillin. So if you're allergic to penicillin, then you can't have flucloxacillin. So we would have to use something else, for example, clarithromycin or erythromycin or perhaps ciprofloxacin. But so there are other options. And it depends also on what grows from the ulcer. So if your doctor has swabbed the ulcer and then that ulcer grows an organism which isn't sensitive, then they would be guided by what we call as sensitivities. And because the bacteriologist or the microbiologist will test against the different sensitivities. So it really depends very much on the ulcer and what's growing on it. People with very nasty ulcers and with bone infection, will need sometimes combination antibiotic therapy. So it will be guided by the clinical situation. So I think it's not really one size fits all.
Thank you, Dr. Herrick. Liz also thanked you for a great talk. Linda has gone on to put forward more of a statement than a question. She goes on to say, I have an ulcer on her knuckle, and her fingers are not bent, but they are swollen. I'm guessing maybe she is asking if they could potentially become bent in future.
Okay. So Linda, I think swelling of the fingers can occur in scleroderma. You can get a sort of generalized finger swelling or finger puffiness, and in fact, finger puffiness, puffy fingers are an early sign often of scleroderma and someone who has Raynaud's phenomenon. So that's the first one. I'm not quite sure what you mean on knuckle. Some people, knuckles mean this one here, which is what's called your proximal phalangeal joint. And other ones, other people think knuckles is this one here, which is what's called your metacarpophalangeal joint. So I'm not quite sure what you mean in that instance by a knuckle. If either of them are swollen, then if the joint itself is swollen, then it could be some swelling around an ulcer, because if an ulcer is infected, then it can generate an inflammatory response, and you can get a little bit of what we call soft tissue swelling. But if I obviously am seeing the joint, but if the joint itself is swollen, then I think that would need to be assessed independently, because that could have a variety of possibilities. And there are obviously a number of reasons why joints can be swollen. So I think you would need to seek a medical opinion on that to find out if it was a joint itself that was swollen, as opposed to some soft tissue swelling.
Thank you, Dr. Herrick. Appreciate that was a bit of a difficult one. We've had a great question coming from Stuart, and Stuart has said that he has been struggling with one ulcer on a single finger that is now scabbed over, but it is taking ages to clear up. Is there anything I should do? For instance, bathe it?
I think it's a little bit difficult to, as a huge generalization, you want to protect it, and protection is much more easily said than done. I'm glad that it's finally healed over. And I think you just want the healing process to take its time. Well, obviously you like it to go more quickly, and eventually the scab will come off when it's ready to. And it's just actually a little bit controversial sometimes as to whether a scab should be sometimes cleaned up. But from what you say, I suspect it's probably the sort of scab that you want to just leave on until it comes off naturally. So I think the main thing is protected. I think you want to keep it clean. I think, and I think just bathing is okay if you just do it gently. Again, I would ask, whoever's looking at it, hopefully your nurse specialist or whoever you have access to just have a look at it. It's difficult to generalize. All ulcers are different, and I think they need slightly different approaches. I think the nursing team are very well placed to look at the ulcers and to give the best advice. But I would just say, as a general rule, protection, and maybe just a dry dressing over it, for if you're out and about and it might get knocked.
Thank you, Dr. Herrick. We've had a question coming from Naoma, and she's made an observation where she has noticed some hardness on her sole and some splitting in the big toenail, and she's worried that this could potentially be part of an ulcer.
Okay, I think a hardness in the sole of the foot is often what in medical terminology we would probably call that callosity. There can be some hard skin. It can be very uncomfortable and really quite painful. And I think the splitting of the toenails, I think it's a separate issue. I mean, the nails per se are not generally affected, but the lesion on the sole, the concern about the lesion on the sole of the foot is that it could represent that there's a pressure point there, depending on where it is, that maybe needs to have the pressure lifted by, good footwear and insole or whatever. The other worry is that you might get an ulcer at that site, And that's, as we've just been talking about, is a problem. But there's another slight side to the story that I'd just like to pick up. You have to be very careful with trying to treat this hardness or hard skin or callosity in the sole of your feet, because I have seen one or two examples when people have gone. I don't like to think about what they took to it, but they've tried to attack it to get rid of it, and it's just become a horrendous mess, because you have to be very, very careful. Care of the feet and people with scleroderma is very important, and please ensure that you have a podiatrist that knows your scleroderma and knows what they're doing, because you don't want to create a wound by trying to get rid of the hard skin. So it does need to be very carefully managed. And and people with scleroderma, the feet should be considered high risk, in my opinion, in the same way as people with diabetes are high risk feet. I think you do have to be very careful with the feet and scleroderma.
Thank you, Dr. Herrick. We've had another question coming from Bridget, and Bridget has said that she has had digital ulcers in the past, but now she has 2 calcinosis lumps on her fingers, which have erupted, and now and again calcium does come out, and there is still calcium underneath, and they are still ulcerated, though they don't hurt too much. She is trying to keep them covered. She goes on to ask if that's the right thing to do.
I think if there's an actual wound there, or an ulcer, then yes, it is a good thing to keep them covered, because they're a potential portal for entry of infection. And so you want to try and prevent this becoming infected. And calcinotic areas can become infected, and they can then be quite difficult to eradicate the infection within them. So I think, yes, you do need to be careful. So I think keeping them covered while they're open, while there is an ulcer there, is a good idea. I think the other 2 aspects of management are just, if it does get red or angry, it may just be what we call a chemical irritation, but I don't like to take any chances on it. So I would get an antibiotic in that situation, just in case I have become infected, to try and knock it on the head as quickly as possible. And if this is really a recurrent problem and is getting a big issue for you, then it wouldn't be a bad idea to ask whether anyone feels a surgical opinion would be beneficial. Although, as I said earlier, surgery is not without its problems. Surgery in the fingers of people with scleroderma is a high-risk procedure because of the poor blood supply, so it has to be done with care. But nonetheless, a lot of people like to have the calcium debunked, and it's helpful. And you have to accept that calcium may just regrow over time, but if it can decompress for a while, then perhaps that's an option for you. So it's something to discuss with your medical team.
Thank you, Dr. Herrick. I'd just like to make everybody aware that we're into the last 10 minutes. So I'd like to encourage everybody to stop sending in questions, just to make sure we can get through the ones that we currently have on our list. So another question is from Brenda. And Brenda has gone on to say that she has had a finger ulcer for over 30 years. Is that the reason for the bones on most of her fingers shortening?
Okay, it's an interesting question, Brenda. I think the quick answer is the 2 issues may well be related. In scleroderma, you can not infrequently get a problem called acro-osteomyesis, and that means that the bone of what's called your terminal phalanx of the finger. There are 3 bones in the finger. Well, apart from the thumb, where there's 2, but the other fingers have got 3 bones, and the furthest, the one at the tip of the finger, called the distal phalanx, can erode, so that there's loss of bone at the tip of the finger, and that's quite classical. A lot of people with scleroderma do not get that, but some do, and the ones who get it tend to be the ones with the most severe digital ulceration and Raynaud's phenomenon and so on. And so that is, I would stress that I can't make statements on anybody's individual problems. I'm afraid I can just talk in generalities, but But so that may or may not be the case for yourself. But the fact of the matter is that yes, the fingers can shorten a little bit. It's not usually a very marked thing though, but it can be. Some patients can have quite marked shortening of the tips of the fingers because of that process that I've mentioned.
Thank you, Dr. Herrick. We've also had a question coming from Marion. Marion, thanks you for your presentation. She goes on to ask about the success of digital sympathectomy in your experience in preventing ulcers. She says, I still get painful ulcers despite being on maximum medication.
Again, I think the success rate of digital sympathectomy is a difficult one, and the literature is now full of what we call case series of patients who have had digital sympathectomies and other surgical procedures. There's always a bit of a publication bias in these things because people will report, or at least they may do, the patients have done well after a digital sympathectomy. So I think the fact of the matter is that not all patients will benefit from digital sympathectomy. That's been my experience. And so I'm not saying that it's necessarily going to be a magic cure that will prevent any further ulcers. I think conversely, some patients do definitely seem to have benefited, and they feel that they have many fewer ulcers post-sympathectomy than they had before, and it's helped their ulcer healing. So yes, I would still recommend the opinion of a hand surgeon, but I think the digital sympathectomy doesn't take away the problem. It hopefully improves the blood flow a bit, but it doesn't take away the underlying scleroderma. So I don't think you can expect it to do any more than hopefully reduce the problem. So it's something which may help, but cannot be guaranteed to.
Thank you, Dr. Herrick. We've had a very interesting question coming from Janet. Janet goes on to ask if preventing a Raynaud's attack, for example, keeping hands warm, etc., help with preventing the formation of an ulcer. Also, is there any evidence that medical grade Manuka honey helps?
Yes, no, there are interesting points. Thank you, Janet. I think theoretically, you would assume that by keeping your hands well perfused by whatever method that takes, whether it be keeping it warm in a warm ambient temperature, or whatever, or taking a whole load of medication, you would, if you believe what I said earlier, that we think that poor blood supply is driving the formation of a digital ulcer, then you would think that all these measures would help to prevent ulceration. I cannot give you any evidence to back that up. It would actually, if you think about it, be a very difficult thing to prove. You would need very large scale studies. Scleroderma is a very heterogeneous disease, and these, I'm not aware of any evidence that definitely says that hand warming will prevent digital ulcers. I think it makes sense to assume that it will help and could prevent them, but there is no definite evidence to suggest that. Manuka honey, I think, is difficult. Again, I'm not. I personally am not aware of any good evidence base, but I know that many people like to use it. So that's as much as I can say about that.
Thank you, Dr. Herrick. Susan has sent in a question asking for more information about Bosentan as an alternative to Iloprost.
Okay, well, thanks very much, Susan. I think Bosentans should perhaps be viewed as a complementary. It could be an alternative. I think the fact of the matter is that we have a UK pathway. NHS England has a pathway for the treatment of digital ulceration. And the currently published one suggests intravenous iloprost infusions first. And because we know intravenous iloprost infusions or intravenous prostanoid infusions are known to help ulcer healing, as well as hopefully preventing them. Bosentan does not heal ulcers. There have been 2 large-scale studies and they've both shown that bosentan doesn't improve healing of existing ulcers. What it will do is it will tend to prevent or at least reduce the occurrence of new ulcers. So we're talking about something a little bit different, although you could argue they're all just part and parcel of the same thing. So I think that bosentan will be increasingly used. I think it's you know, while in some ways we shouldn't let costs enter it too much, I think it's only sensible to realise that for a drug that costs, you know, in excess of £20,000 a year, which is what it used to, it is going to be a little bit difficult, whereas now it's very, very much reduced in price. So I think that is one factor which will bring it up the pipeline. And the other factor is that we have, as I mentioned earlier, and as you all know, we are trying to reduce hospitalizations with COVID-19. So, well, A, because there's increased pressure on beds, and B, a lot of people don't want to particularly come in if it's not necessary. So I think there has not been a head-to-head study, well, a good head-to-head study comparing bosentan to iloprost. There have been one or two smaller studies, and I think probably, you know, for people with bad ulcers, I think they may well be a dual approach. You know, you may be on bosentan, and then, but also, you know, for a particularly troublesome ulcer or crop of ulcers, you may need to come in for a series of iloprost infusions. But so they work in different ways. They're different types of drug, and so I think there are different aspects to the armamentarium that's available to us. Bosentan, I should say, can only be prescribed at the moment by specialist centres. So if you don't attend the specialist centre, then your doctor would need to discuss a position with one of the specialist centres. But I mean, that's done all the time. And they can make the recommendation if they feel it's appropriate to prescribe a bosentan and then prescribe it. The bosentan needs blood monitoring. So those of you on bosentan will know that you have to regular checks initially every 2 weeks and then every 4 weeks. So there is a commitment on your part as patients. If you're having bosentan, you have to get the blood monitoring because it can sometimes upset the liver tests and occasionally the hemoglobin. So you do need regular blood monitoring on bosentan.
Thank you, Dr. Herrick. We are about to wrap up, so I'd like to say thank you so much, Dr. Herrick, for the amount of great detail that you've gone into in the Q&A session. And a huge thank you for your overall involvement from myself, from everybody here at SRUK, and from the whole community. And I'd also like to thank all of our community and attendees for sending in your questions, for participating, and for making the session what it is. I am sorry we weren't able to answer all of the questions. There were a few questions that we unfortunately ran out of time for, but I do hope we have answered the key questions around this topic. And this webinar recording will be going up on our YouTube page and will be shared on our social media, as will the presentation, just to make everybody aware. But finally, thanks again, Dr. Herrick.
Thanks for the
presentation. And I'd like to wish everybody a lovely Tuesday. Take care, everyone. Bye-bye.
Thank you. Bye-bye. Bye-bye.